Okay, I'm so glad that I could be part of this meeting. I'm Robert Post, and I'm with Chobani, and I was on the planning committee, and I'm very excited to be here to see it all come to fruition. It's a day chock full and a day and a half chock full of different topics and different aspects on a very important issue. And every aspect becomes even more intriguing as we hear about it. And to be complete, we wanted to get a sense of national programs that address dietary needs of older populations. And so the next session is all about that, and we've got a great panel of speakers. And the first one on the agenda is Bob Blancato. He's with the National Association of Nutrition and Aging Services program. And he's going to talk about the outlook on legislation on nutrition and aging. Bob?
Thank you very much for the introduction, and thank you all for coming back. Those of us on last panels always want to make sure that, we have people to talk to. So it's an honor to be here this afternoon, and commend the IOM for having this workshop on dietary needs of older adults. And I'm proud to be associated with the National Association of Nutrition and Aging Service Programs, which represents a number of service providers around the country who support nutrition, health, and life quality for seniors. And we're working to reshape the future of nutrition and healthy aging, which belong together and have for years. And we're pleased to work very closely with our colleagues from the Academy of Nutrition and Dietetics. So I decided that what I should do, since I'm supposed to be a policy person, is put us right on to where we are right now. As we are sitting here at 21st and Constitution Avenue, the Congress is doing something which, as of Sunday, didn't even exist. Meaning that in Washington, brinkmanship is always the way things get done. You need a deadline, you need a problem. In this case, having a debt ceiling run out on November 3rd has prompted Congress to suddenly develop a 2-year budget agreement, which was unveiled Monday night and may very well pass the House of Representatives tonight and may very well pass the Senate tomorrow. And, for the concerns of older adults and nutrition, it's actually a good deal. Notice I didn't say perfect deal, okay? It's a good deal. And the reason it's a good deal for anybody who's involved in federal programs is that with the passage of this budget resolution, there will be no return to sequestration or across-the-board cuts through at least September 30th, 2017, and chances are you'll never see them again if it goes that long. And with that in mind, you have a $40 billion increase over 2 years in what they call non-defense discretionary programs, meaning many of the programs that we are involved in our work. And if you follow the President's budget from this year, who decided that he said it's time that we start investing in programs versus going back to sequestration, 2 examples of what could happen if this budget agreement were to pass. His request for $60 million in funding for the Older Americans Act nutrition programs could well be approved, or portions of it. And the President's request for $83.7 million for a SNAP program of an increase of over $2 billion, almost $2 billion, could also be improved and included. And we're hoping that history repeats itself. We had a last budget agreement a couple of years ago, and then asked, and my colleague Ellie Hollander from Meals on Wheels America is here, and we worked together to get an increase for the Older Americans Act nutrition programs. So let's talk about the Older Americans Act for a second. I'm going to make sure I got my slides right here. This is a program that's been one of the Great Society programs. It's celebrating its 50th anniversary this year. Its largest program has been, for its history, the nutrition programs, congregate meals, home delivered meals, and nutrition service incentive programs. At current funding levels, it's allowing 224 million meals to be served to 2.5 million older adults 60 years and over. And the Older Americans Act provides meals, nutrition education, and socialization for its participants. And the part that we're a little frustrated on as the years progress is that we know that the Older Americans Act, by its very existence, is saving countless millions of dollars in Medicaid and Medicare. And the reason it's countless is because it isn't counted. It isn't used as part of the data collection that should be done. So laws have to get reauthorized. The Older Americans Act was due for reauthorization 5 years ago. Half the Congress has addressed it. The Senate has passed its bill, a modest 3-year reauthorization of the Act. One of the provisions it talks about is strengthening the use of registered dietitians in the nutrition program by utilizing their services. But now we have to get the House of Representatives to act, and so far, we have not seen much action on that side, but the advocacy continues. The President, at the 2015 White House Conference on Aging, did call for the reauthorization of the Older Americans Act, which did prompt Senate action and get them to pass the bill. As you know, many programs don't get reauthorized, but funding does continue, even if they've technically expired. But it's not really comfortable to have your program not get renewed, and it's also a time in history when we should be focusing more on future directions of nutrition and older adults and its relationship to health. And if you add the advent of managed care into many communities, we suddenly find nutrition services more relevant at the community than ever before. So this is just a chart to give you a sense of the funding situation with the Older Americans Act, and since all these presentations will be available later, I will not spend too much time on this chart. But, you know, it's beyond Older Americans Act funding when we talk about nutrition. We find that the Medicaid program for many communities is a new and deeper source of funding for nutrition programs. And if you look at this one statistic, which, you know, I'm fascinated by, how much funding for home and community-based services under Medicaid, including nutrition, has increased just since 1990, it tells you that the notion of rebalancing our federal health care dollars is beginning to work, away from nursing home care into home and community-based care. Medicaid expansion under the Affordable Care Act is bringing more older adults into the program. Funding for total Medicaid will continue to grow, and managed care alone will grow to $193 billion a year by 2024. And we have states administering Medicaid waiver programs that include nutrition as well. The Affordable Care Act, you know, is, first of all, for those who are supporters, you know, the outlook for the law, I think, is finally good. You know, I refer to it as the American Conversation Act because it's 5 years old and everybody still talks about it and have many opinions on it, one way or the other. But since the Supreme Court handed down a couple of rulings, now we know that the basic law will continue. So there'll be some changes made to it. I think both sides are agreeing that we can make some tweaks to the law. You know, more states may join on the Medicaid expansion side. But, you know, because of the Affordable Care Act, we have an annual wellness visit under Medicare, and we have 23 states now requiring some form of nutritional counseling and therapy to be covered as an essential health benefit, which we think is very important. I know one of our panelists will be talking about care transitions, so I'll be brief on this, but, you know, this is another provision of the Affordable Care Act, you know, aimed at trying to reduce hospital readmissions, which is costing Medicare a lot of money, and part of the reason why we have so many readmissions is that at the community level we don't have good programs for people to be discharged back into. And so there's a number of models out there to test care transitions from the hospital to other settings, and many are run by the Aging Network. But we're of the view that you know, not enough emphasis so far has been placed on nutrition in these care transition programs, and we'd like to see the programs extended, but in the new models that go forward, more of an emphasis on nutrition. Briefly, there's another program that doesn't get a lot of attention from the nutrition perspective, but it should, which is the Social Services Block Grant. It used to be Title 20 of the Social Security Act. You know, it serves many groups of people, but $30 million of its budget goes to elderly nutrition, including $25 million for home-delivered meals. And every budget cycle, even though this is the most intergenerational program you can find, it's always on the chopping block, and always people are threatening to defund it. And so we spend a lot of time as advocates making sure this program does not get cut or defunded. The Farm Bill, many of you follow that. You have USDA people here. It was renewed and has very important domestic nutrition programs, the SNAP program, the Senior Farmers Market program, which, you know, from the time that was established, I've always felt that was one of the greatest win-win programs we ever created. Low-income older adults win because they get access to fresh fruits and vegetables. The small farmer wins because he has a whole new market to sell their products to. It's a wonderful program, but it struggles to get funded properly. And the CSFP, which did transition to an older adults program, now is serving over 500,000 older adults in 49 states. And again, another chart showing you a funding level, but the President's budget number, the second one on the top there, is what I referred to earlier. This budget agreement will allow the flexibility to perhaps get to that number as compared to being worried about 5% across-the-board cuts or other cuts. So we have our fingers crossed. Anybody who is following this budget, go like this for the next, 48 hours, and hopefully it'll get done. Medical nutrition therapy is, there's need for an expansion of that. It hasn't really been touched much since about 2002. And there's a bill in the Congress by Congresswoman DeGette to expand coverage under Medicare to people with prediabetes and risk factors for type 2 diabetes. And again, Medicare is now and should be moving more toward the preventative side of the ledger, and there are more preventative benefits in the past 10 years in Medicare than there were in the previous 40 years. So that's a good trend, and I think that's a trend that's caused by the boomers finally getting to the point of being eligible for Medicare. I was asked to talk a little about the White House Conference on Aging and what actions may come from that. It was held back in July of this year. It's the 6th one in our nation's history, the 2nd of the 21st century, and it was held, of course, in the great anniversary year of 2015, with all those programs and more celebrating anniversaries. And it's appropriate time to have a White House conference. They have them every 10 years. The goal is to help set national aging policy for the next 10 years. And the conference focused on 4 topics, two of which have direct bearing on nutrition in older adults. One is healthy aging, and the other was long-term services and supports. Healthy aging, as defined by the White House Conference, was living a long, productive, meaningful life and enjoying a high quality of life. Or as I used to say when I first saw this on the agenda, who could be against this? It's one of those no-brainers. They issued a policy brief background paper. They had one paragraph in that paper on nutrition, citing existing programs and resources in reference to importance of healthy diet to disease prevention. In the long-term services and support section, they defined it as health and social services that may be needed to maximize the independence and well-being of an individual. Well, obviously, nutrition is critical to that being achieved. They issued a policy paper again. Nutrition as a critical component was briefly mentioned in the paper, but the growth of managed care and among those on Medicaid and the importance of nutrition in those programs was not necessarily cited in the White House Conference. At the conference, these announcements were made, one dealing with the proposed rule of USDA to increase accessibility to critical nutrition for homebound older adults. PPOT adopted best-in-class web accessibility standards, and the National Prevention Council announcing in the spring of 2016 it will release a healthy aging action plan to advance the national prevention strategy. And a lot of us in the field will be working to see that be as strong on the nutrition side as possible. But these were all announcements that were made at the White House Conference, and follow-up will come from it in the months ahead. But what follows from the White House Conference, it's a little unclear at this moment. Most White House conferences conduct their conference and issue a final report with recommendations and resolutions that can be acted upon. The administration laid out a whole series of initiatives in the White House Conference, all of which they can do themselves. And now the responsibility for advocates is to see those dates met and those rules and regulations and policies adopted. And a lot of them had timetables on them, so that's a good thing. New legislation may also follow from what was produced at the White House Conference on Aging. That would be consistent with history. But we're just not sure yet, and it's going to take probably another month or two before we know what the outcome of the White House Conference was. But in my judgment, where should the focus be if we're talking about healthy aging? It has to be on the triple threat to older adults and healthy aging: hunger, food insecurity, and malnutrition. And many of the solutions are the same to these problems, but some do differ considerably. Malnutrition is an area of new focus because malnutrition is simply poor nutrition related to excessive or imbalanced diet, clinical conditions that impair the body's absorption and use of food, and a diet that lacks essential nutrients. We know it has cost estimates that have been developed, and there'll be more to follow, that the burden is now at a point of about $156 billion a year. Malnourished patients are more likely to experience complications, which makes it, again, the health consequences of malnutrition very significant as we start focusing on this area of concentration. And you look at solutions that could be put forward to address this, and these are just some of them, and they'll be in the full presentation. But the top one is to make malnutrition the key indicator of older adult health. To re-examine the older adult goals of Healthy People 2020, something that is actually underway right now. There's a comment period open till November 15th to submit revisions to that plan, and we're involved in that right now. Address sarcopenic malnutrition in national and state obesity plans. Re-examine the protein requirements of older adults and consider the need for an increased protein dietary reference intake for older adults. And expand electronic medical records to include standardized section on malnutrition. These are some of the ideas that are being considered. Include malnutrition screening and intervention in essential benefits and Medicare's annual wellness exam. Make sure that that is discussed as part of the wellness exam. Include coverage for oral nutrition supplements for malnourished and at-risk dual-eligible populations. Again, data is another piece. Collect the right data to improve outcomes with malnutrition screening. And expand medical nutrition therapy coverage to include malnutrition. These are ideas that are just beginning to circulate, and we're hoping that we can move them forward in the coming months, because we have created in Washington a new coalition to position malnutrition as a key indicator and vital sign, and it's called defeatmalnutrition.today. And I want to commend my colleague Meredith Ponder, who's sitting out here somewhere in the audience, who works with me on this project and a lot of these projects, and she's a lot younger than I am. I didn't even know .today existed. So we're now very proud to have this as a wonderful new title for a coalition. And you'll see on the resource page how to follow up with us on this. I was also asked to, address a question about how to ensure that older adult malnutrition and food insecurity become as prominent in national policy dialogue as concerns for children's health and trends for diet-related illnesses. How do they compete, and should they? I thought it was a very sad state of affairs to have that question even asked. I definitely see a need to raise the prominence of issues around hunger and food insecurity and malnutrition, but not at the expense of what's being done for children. The real answer is that we need to improve our federal commitment to vulnerable people of all ages. A hungry child and a hungry older adult are both tragic. And the goal of policy should be to promote good nutrition and nutrition education throughout the lifespan. We've got to start focusing on our policy directions on the intergenerational basis, where we can and where we should. Promoting better outreach and access to programs, because to be eligible for programs, and my colleague from the National Council on Aging is here and will be on a panel with me, and they spend a lot of time, I'm on their board, dealing with benefits access. Benefits access. People who are qualified for programs who don't get them because they don't know about them, it's a tragedy, and it goes through all the generations, and we should be spending much more time and attention on that. So the way to raise prominence, in my judgment, is to discuss the consequences of hunger and food insecurity and malnutrition to the health of older adults. It's time to remove the cloak of denial on these issues as it relates to older adults. We should discuss how nutrition interventions can prevent hospitalizations and nursing home placement, making them a greater value to be considered from the policy perspective. And we should commit through greater, robust public-private partnerships to tackle all these threats to healthy aging in America. It's being done in some areas, but it should be done across the board for all three. And then, of course, from the advocacy standpoint, we in the elderly nutrition space could learn a lot about doing better advocacy by working with our colleagues in the children's world. When you look at the funding levels of different programs and compare them to what we're doing with Older Americans Act nutrition, it's pretty stark. But, if you take the view that the role of government is to respond to the needs of the vulnerable of all ages, then we should be working to increase the funding levels for these kind of programs serving the vulnerable older adult. And it's no surprise to anybody in this room that government dollars are spent more wisely when you invest in prevention. And, we're talking about, investments versus expenditures. You hear about budgets and you hear about this and that, but talking about prevention as an outcome is very important. And good nutrition for older adults is an achievable goal, and we should be working to achieve that goal. We need to create more of a political imperative for elderly nutrition. We need more outreach and enrollment in SNAP. We need greatly increased funding levels for the other programs. And for the Older Americans Act, let's get down and discover the reality of how much it has saved the bigger programs like Medicaid and Medicare, and then fund these programs because they're a good value. They're a good use of the federal dollar. But unless you collect the data to show what those savings really are, you're not going to be able to make that case all that effectively. So I commend the IOM for conducting this workshop, and I look forward to further collaborations. And in the 1 minute and 30 seconds that I have left, I can keep this resource page up, but say thank you in the meantime. So thank you very much.